All right, thank you. Excellent. It doesn't look like we lost too many people. Everybody still appears to be breathing. I don't see anybody who's asleep, so this is all good. So the next part of the talk is about dementia and different types of dementia. And then there's also, I'm going to talk about dementia with behavior disturbance, what that is, how to treat it. And so I am going to try and tie this all together as we go, but let me know if I don't. So I have, Sarah Feudel is an occupational therapist, and Maria Schindler is a nurse, and I have worked with them. We give an invited course at the American Psychiatric Association meeting. This will be our 6th year of doing this, and we sort of looked at a lot of the literature. This is not rocket science, but this is sort of, we put this together as a therapeutic approach to dementia care. And when I actually looked at it, I thought to myself, well, it's actually just a great therapeutic approach to any care, right? I mean, so people with dementia are still people and need to be approached, sort of their challenges. There's a framework for approaching them, but it's not that different from the framework for approaching anybody's challenges. So the key first step is the identify and assess. And that's the part that people want to skip over, right? Especially if you're only getting called in a crisis. But it's the most important part, because you cannot do an assessment, an intervention, if you didn't do an assessment. So last week, a nurse walked in, a new nurse at our agency walked in, and she said, Dr. Nash, what's the rescue medicine I should be using when somebody calls me on the weekend for behaviors? And I looked at her and I said, so what do you do when you get a call for chest pain? Right? What causes chest pain? Well, heart attacks cause chest pain. Pneumonia causes chest pain. Rib fractures causes chest pain. A knife sticking out of your ribs causes chest pain. And the treatment for all of these things is very different. And it's not, so there is no such thing as behaviors. There is a behavior. What is it? Define it. What does it look like? What's the history of it? And then do an assessment, and that's how you select an intervention. And everybody wants to skip over that phase, and I can tell you why, because that's the hard part. And we all like to do the easy part. Except there's some of us, you can sometimes find somebody who's really curious and gets really engaged with the hard part. So, and that's the part of the person you want to find. You want to find the little curious part of them. We all have it somewhere. So you want to, very first thing when you have somebody who has dementia, you want to identify, do they have any unmet physical or psychological needs? The very first step. Are there any environmental causes? Like what's going on in the environment? Do they have psychiatric symptoms? What does that mean? Well, that would be psychosis, major depression, mania, mood disorder, anxiety disorder. This is the key stage. The assessment stage is the key stage for cognitive and functional, formal screening tests. Behavioral scales are I'm a big fan of them. The Neuropsychiatric Inventory is one of my favorite. It defines behavior disturbance very specifically and tells you how to look for it. And it looks at both the behavior disturbance and caregiver distress. Because really, caregiver distress is important to pay attention to, because if caregivers are stressed and distressed, the people that they care for are unlikely to be doing as well as they could. So once you have done your assessment, then you can select interventions and apply them. So, and what kind of interventions are there? There's caregiving approaches, teaching caregivers. There's adapting the environment. And these things, keep in mind, a person with dementia has either severely impaired ability to learn or no ability to learn. So it's not about changing the person. It's about changing where the environment around them, the people who are caring for them, and how they interact with them. And that will change them. That will lead to changes in how they behave, but it's not by directly changing them. You know, well, just stop it. Well, that's a great thing to say, but not effective. It doesn't work with children, and it doesn't work with older adults, and frankly, doesn't work with many of us. So, evidence-based interventions. There's a lot of literature, a lot of small studies, most of which unfortunately are not well done, on various environmental interventions. There's evidence for these things while they're occurring. The challenge is that when those activities or events stop, the benefits of them usually stop too. Not all the time. It's an area of active interest. More evidence will be forthcoming. Currently, there's not a lot of good evidence. The evidence currently supports strongly staff training and caregiver approach, changing caregiver approach. So you apply your intervention, you've done your assessment, you applied an intervention, then you just have to monitor, right? Is it helping? What's getting helped? Is anything getting worse? You know, if it's helping, you might want to keep doing the same thing. If things aren't getting better, you might want to try something else. You know, the old, you know, what's the definition of insanity? Doing the same thing over and over again, expecting a different outcome. So back to the neurocognitive disorders. Basically, there's core deficits, and then you have to have functional decline. That's how you get to it. And that's a really important part. So the most challenging group of people to tell whether there's a functional decline are people who didn't have a good functional level to begin with. So people with developmental delays, people with severe chronic mental illness. It can be a challenge. And getting good history when you can is the most important thing. Neurocognitive disorders are caused by brain structure changes, like a stroke or damage to one area of the brain, brain functioning changes, or changes in the brain chemistry or the neurotransmitters running around in your brain, helping your brain work better. And so if you know what's causing them, then you want to be clear about that. Here is how a psychiatrist, a neurologist, a neuropsychologist thinks about brain functioning. It's really divided up into multiple domains. So there's complex attention, divided attention, sustained, and selective attention. That's what allows us. So if you just sort of think about it, right now your brains are getting, I don't know, multiple millions of bits of information from your central nervous system. Your brains are getting feedback from every cell of your skin about temperature and pressure. Your brains are getting all sorts of feedback through the auditory system, through the visual system. Your brains are getting feedback from your arms and your legs and all of the nerves. So your brains are getting tons of information. But the good news is most of you probably have good complex attention, and so you're sort of able to, the stuff that's steady state, your brain just ignores it all, right? So the ambient temperature, you're much more likely to notice a change in the temperature than the current temperature. You know, you don't really pay attention to all that information from every cell in your skin. I mean, if you did, you'd sort of go crazy, right? So complex attention is being able to attend to a very narrow bit of information that your brain is getting. Executive functioning is kind of what it sounds like, the ability to plan, sequence, carry out an activity and monitor what you're doing and the effect of it and making adjustments in what you're doing to get to a goal. Learning and memory are a big domain of brain functioning. Social cognition, being able to recognize other people's emotions, being able to recognize your own emotions and what it means. Perceptual motor, so the ability to use tools, the ability to move through a 3D or 4D environment. And then language. So there's the ability to express yourself with language. There's the receptive, the ability to receive language and understand it. So those are all, when I think about brain functioning, that's sort of how I think about it. And there's lots of things that can interfere with it. And so these are Probably in order of prevalence. Alzheimer's disease, by far the most common cause of a neurocognitive disorder. Lewy body disease, second most. Lewy body disease and Parkinson's disease dementia are spectrum illnesses, and they're both Lewy body illnesses. Frontotemporal lobe dementia or frontotemporal dementia. Vascular injury causing neurocognitive changes. Traumatic brain injury. HIV causes severe cognitive changes in many people who have it. And then there's sort of all sorts of much more rare Huntington's disease, alcohol-induced changes. There's sort of hundreds of them. But if you just look at the top three, Alzheimer's disease, Lewy body disease, and frontotemporal dementia, you're probably covering about 90%, at least of dementia types. So I already covered all that. These are symptoms, these are common symptoms in neurocognitive disorders. Psychosis, mood disorders, apathy, agitation, and then sort of, there's always the unknown other, unspecified other, or specified other. So this is, there's a lot of different research out there, and you get different numbers, but basically most people will tell you that between 60 and 75% of people who have dementia have Alzheimer's. Different studies will tease it out differently. And then 15% or so of people who have dementia have Lewy body dementia or Parkinson's disease dementia. About 10% of people have a mixed dementia, so multiple causes. And then vascular dementia. And I would say that frontotemporal dementia is probably about 7% of people who have dementia. It's a little more challenging to pick up sometimes. So Alzheimer's disease is always the elephant in the room. Alzheimer's disease is a type of dementia. It's the most common kind of dementia. So sometimes it's called Alzheimer's disease, sometimes it's called dementia of the Alzheimer's type, sometimes it's called Alzheimer's dementia. And it's sort of the classic, when most people think of dementia, this is what they're thinking of, somebody who has Alzheimer's. There's a clear evidence of decline in memory and learning, and there's a steady progressive decline. And that's the decline in memory, which starts out as trouble forming a new memory and ultimately becomes a total inability to form a new memory, which is extremely disabling. The functional decline that you see in Alzheimer's is not quite so steady. In Alzheimer's disease, in the first 5 to 7 years, which the vast majority of people are not diagnosed with it during those years, there's a very slow functional decline in their ability to function in the world. In the moderate phases, there's a much more rapid rate of decline in people who have Alzheimer's. And that's where most people are diagnosed. And most people who have moderate Alzheimer's disease and are declining, and it's sort of every 6 months you can say, oh wow, this person is really different. Their functional level is really different than it was. But unfortunately, because we're not so good at diagnosis, most of those folks are actually told that they have mild dementia, when in fact they have moderate dementia already. And then when you get back to severe dementia and end of life, that is usually about 2 years or so, although there's always a range. Someday, perhaps not too distant future, we will have some genetic markers that actually make sense to measure, or some imaging tests. There are some sophisticated things we can do. None of that is standard clinical standard of care because there's no good evidence quite yet for those things. Frontotemporal lobe dementia or frontotemporal neurocognitive dementia, it too has an insidious onset, and there's 2 different variants. There's a behavioral variant, and then there's several language variants. And the behavioral variant, from an airplane view, will look, you either have this apathetic type of illness, and it kind of looks like depression a little bit, or there's this sort of manic, socially inappropriate, severe impairments in judgment type. That again, from an airplane view, might look like mania, but really isn't. There's almost always significant executive functioning deficits, so that ability to make good judgments, make good decisions is impaired. The language variant, much less common, but when you see it, it's really pretty severe. So there's what they call semantic dementia, or primary progressive aphasia, and that's where people first they lose the ability to use nouns, and then they end up with kind of salad speech. And there's this other language variant where people's speech becomes very like a telegraphic speech. They sort of lose all those connector words, and they just sort of use the main words, and sometimes end up not using language at all. That last type is the most easy to diagnose. It's very obvious, and it has a pretty quick trajectory or course. In early frontotemporal lobe dementia or frontotemporal dementia, there is really not a significant noticeable impact on memory. And so that, this is actually why they did this is what led to the change in how psychiatry looks at dementias, is because this doesn't fit in a mold like Alzheimer's. Lewy body disorder also has an insidious gradual onset. And so with Lewy body dementia, the first symptom is usually visual hallucinations or some sort of delusional system. And there's often gross changes, like people can be really confused and out of it and very paranoid in the morning. In the afternoon, they're just like normal, and they can remember the morning, and they can say, well, you know, that was just a weird thing. I don't know what that was about. And then by the late evening, they're different too. And so it's this, you know, with Alzheimer's disease in general, you know, there is this decline, and people don't have these rapid fluctuations in a single day, whereas in Lewy body, it's almost always. There are suggestive symptoms, features, so REM, sleep behavior disorder, where people are sort of acting out dreams, and if you give somebody an antipsychotic, also called a neuroleptic in some places, if you give them that, they tend to have severe Parkinsonian type reaction, or in fact can have psychotic symptoms as a result of it. That's not, you can't use that to diagnose it, but it is suggestive and makes you want to consider it. So if, and movement disorder does occur in Lewy body dementia, but it starts more than a year after other symptoms. People who have Parkinson's disease, it starts with the movement disorder. So the tremor that people with Parkinson's disease have, and the masked faces, and their gait changes, their writing gets really small, all those things. So if the movement disorder happens first, then it's Parkinson's disease. If these other symptoms happen first, then it's Lewy body. But if you take two brains of two people who had Lewy body dementia for 20 years or Parkinson's disease for 20 years and put them under a microscope, you're not going to be able to tell the difference. They're going to look the same. It's just where the Lewy bodies start, and if you wait around long enough, they will increase in locations of the brain. And then vascular. So, you know, vascular dementia, I think, is a little bit overdiagnosed. I'm not a big fan of diagnosing it unless somebody has had a major stroke. And you can see a stroke on a CAT scan or an MRI, and the symptoms, you know, occurred right after the stroke. There are these sort of what people call white matter changes or chronic ischemic changes, these little white dots you get on CAT scans and MRIs when you look at a brain. And those are little areas of the brain that are dead. That condition is just, it happens in people who don't have any cognitive impairment. It is very, very common in people who have Alzheimer's disease. It happens in people who have high blood pressure. So I'm just a little, I think that those folks usually have a mixed Alzheimer's and vascular type dementia. And I usually treat those people as if they have Alzheimer's. So, but when you are looking at people don't come in like with a, you know, like on commercials, sometimes you see like people come in and they'll have like a symptom or a diagnosis on their head that you can read. Well, people don't walk into your office like that. They don't walk into your care facility like that. People come to you either because they have symptoms that they can't figure out or somebody else can't figure out that are bothering them, or their functioning is changing. And so, you know, the purpose of treatment, I think, at this point, since we can't prevent or cure any type of neurocognitive impairment in the dementia line, is you want to manage the symptoms that people have to decrease their personal suffering, and you want to change the environment to support them at whatever functional level they are at so that they can function the best that they can. And so this is why, if you have somebody who has Alzheimer's disease and they're living in the same place they've lived for decades, right, they're gonna look like they don't have moderate functional impairments in their day-to-day life, because they're relying on all this long-term memory. But their primary deficit is this inability to learn new things. And so you take that same person who has Alzheimer's disease, who was sort of making it in their, you know, there were little problems here or there, but they seemed to be making it where they were living. And you take them and put them in a new environment, say they just move into a foster home or an assisted living, and all of a sudden, oh my gosh, they are impaired, man. You know, you didn't tell me you couldn't do this, that, or the other. Well, they could do this, that, or the other when they knew where everything was and when they were doing it in the same order they'd always done it in. But you put them in this new environment, they can't learn things, and their impairments are much more obvious. So that tells you that a person's level of functioning, you know, the person themselves isn't the key determiner of how it appears. It's the environment in which you find them. And so that's why sort of changing the environment is really, really key. So diagnosis in dementia, delirium, and everything else is never derived solely from testing or imaging. You know, the places where that might be not true would be imaging coronary arteries, you know, looking at cancer cells under a microscope, but everything else in medicine, it's really history, observable symptoms, course of illness, pre-existing level of functioning. And the thing to know about most people who have dementia is this loss of functional ability and the loss of verbal abilities. That's what drives the disability in this illness. And the loss of verbal abilities is really important. If you take nothing else away from today, people who have dementia, Alzheimer's disease, moderate to severe Lewy body disease, frontotemporal dementia, those folks, the language centers in their brain aren't working right. It's most severe in Alzheimer's, but it's not working right in any of those illnesses. It actually, that part does work fairly well in people who have delirium. You know, they can usually understand what the words you're using mean. But that's very different from moderate to severe Alzheimer's disease. And so what that means is we, without thinking about it, we judge other people's abilities by their use of language. Our brains are very much language oriented. And so you listen to people, you listen to how many syllables they use, what kind of vocabulary and grammar they have. And that's why people who speak a different language and don't know English so well can seem pretty impaired when in fact they aren't. People who don't have much education can seem much less intelligent than they are. And people who are very educated can seem lots more intelligent than they truly are. So, but that all happens kind of in the background, and we don't even really think about it, but we make those sort of judgments and expectations of people based on language. And when you ask somebody something and they don't answer you, or they give you an answer that doesn't make sense, what is the thing almost everybody does? Repeat the question. That is exactly it. Well, if the reason they didn't answer it right, or they didn't answer it at all, or they didn't answer it well, is because they didn't understand the question in the first place, you are unlikely to get what you want, which is information, right? So, but that's sort of, it's human nature, it's how our brains are wired. We are very language dependent. And what I want you to think about, if you have somebody who's dementia, language should not be the primary way you communicate with them. And that's a big change for all of us. So what you need to do is use lots of gestures. You want to ask somebody, you want to say, can you use this pitcher to pour water in this? And then you hand it to them. But you showed them what you wanted them to do, right? So that helps them. They may understand some of the words, but they may not understand what you were really asking. But by showing them, that's appealing to a part of the brain that actually works pretty well in Alzheimer's disease until very, very late. That's one of the reasons why I had a patient with frontotemporal dementia, and he couldn't talk anymore, but he could sing. And he could answer your questions by singing the answer, but he couldn't say it, right? It's a different part of the brain. Music and song live in a totally different part of the brain than speaking language. So if you don't get a good answer, or you don't get the answer you're expecting, or it doesn't make any sense, you're always going to repeat the question. It's human nature. But when you still don't get what you need, think about it and think, oh, I need to use some other medium. So sometimes writing it down helps. But think of some other way to communicate besides just repeating the question, or even worse, just saying it a lot louder, because they're old, so obviously they're hard of hearing. So that's a good way to really irritate older adults. So what do you want to assess? And again, this is specific for dementia, but it's also really any sort of behavioral challenge. These are what you want to look at the patterns of behavior. You want to look at a person's ability to sequence motor steps. When they get dressed, do they put things on in an order that makes sense, or are they putting their underwear on over top of their pants? ADLs, activities of daily living. Social skills, are they picking up on cues? Physical signs of pain. People who have dementia cannot tell you that they're in pain. There was an interesting series of studies done in older adults in hospitals, and it turns out older adults in hospitals assume that nurses know when they're in pain, so they don't mention it. Nurses in hospitals assume that patients will tell them that they're in pain, so they're less likely to actually ask. You can see that this is not a great way to get your pain treated. So there's narrative, and one of the things, again, a big highlight, narrative speech and language is language dependent, sort of by definition. So people whose brains are having problems with language, that's not a great way to get information. You can get information from other people that way about the person, and recognize that that's coming through that person's filter. How do you tell normal aging from dementia? This is actually a kind of a nice 8-item questionnaire. So, is there repetition of questions, stories, or statements? People who have advanced Alzheimer's disease have that inability to form a new memory. So, when they ask you where they are or where you're going for the 500th time that day, it's the first time for them, because they don't remember ever asking that. They just know that they want to know the answer. But you, on the other hand, oh my goodness, I already told you that. I just told you that. What's wrong with you, right? Those are all normal responses, just not particularly helpful. Are appointments forgotten? And this is the saddest one. I can't tell you how many people who have early dementia who start to miss appointments, and they get fired from their doctor's practice, or they get fired from the dentist's practice because of sort of all the financial pressures that everybody is under. But it's really, that should make you wonder, is there something wrong with their brain? If this is a person who didn't used to miss appointments but is now. Poor judgment, like spending all the retirement money, poor driving decisions, difficulty with financial affairs, difficulty learning new things or operating things that you used to know how to do. So like if you never knew how to use an electrical drill, it's not a good test to hand somebody one. But if this was a carpenter, then absolutely, they don't know how to do that anymore. That's a big sign. This is somebody who's severely impaired no matter how they sound when you talk to them. The correct month and the correct year. Most of us can get that. Actually getting the actual day of the month can be a challenge, especially now that, fewer people write checks, fewer people write things at all. It's all sort of online. Not many people read a daily newspaper anymore. But the month and the year or the season are pretty key and easy to tell. Decreased interest in hobbies and usual activities, overall problem with thinking or memory. So this is a nice little screening to tell, because what's normal aging cognitive changes? Well, people think more slowly. It takes them longer to figure things out, to think through things. And in fact, if you think, well, they're going through 85 years of events to answer your question, whereas, you're only going through 30, whatever. So takes them longer. They need more repetition to form a memory. That's normal aging, but they can still form a new memory. So there's lots of scales. Formal neuropsych evaluations they're good for people who are really educated and really early in the illness, but until things change, that's not very common. Because by the time somebody has noticed there's a problem, they're almost always about to be moderately impaired or already moderately impaired. What do you want? You want a brief scale that's inexpensive, that is reliable and valid and easy. So there's a couple out there. So SLUM, St. Louis University Mental Status Exam, mental state exam. So this is pretty standard. It's on the internet. You can find it. I like this for people who have a high school education or less. People can often do this up until, don't get frustrated with this even if they have moderate impairment. The MiniMental state exam, who here does a MiniMental state exam? Who here was trained to do a MiniMental state exam? All right, well, that's good. So I don't have to tell you why not to do it. MoCA, Montreal Cognitive Assessment. This is a great tool. It is in 30 different languages or something. It has nice norms for age and education level and gender. So there's a lot of information about it. The challenge with it is that if somebody has moderate impairment, so their conversational speech sounds fine, and you might not even notice there's something wrong, but that group of people gets very frustrated because the first part of this test is the hardest part. This alternating numbers and letters, so 1A, 2B, and then drawing that diagram, which seems potentially like it might be simple, and then drawing a clock without a clock face without actually getting a circle provided to you. Those are really challenging things to do if you have moderate or severe impairment. And you can't always tell that somebody has that level of impairment in a conversation. So just for my clinical practice, I only use this in people who are really have college education or higher, or are really smart, ran a business or something, sort of as a substitute for lots of education, and people who I don't think are significantly impaired, because they can do it without getting frustrated. Because the problem is if somebody gets really frustrated in the first couple questions you answer, what are they likely to do? Stop answering questions, which just doesn't help. The Trailmaking Test, so there's Trails A, where you just sort of link numbers 1 through 25. And the normal thing for that is to be able to do it in a minute or less. You time it. Trails B is actually the test that you want to do. It's an executive functioning test, and it's complex attention. You have to go back and forth between numbers and letters. The nice thing about Trails B is that in Oregon, the Department of Motor Vehicles uses a Trails B test as part of their should I be worried about somebody's driving. And so if it takes 2 minutes or longer to do this test, then they really should have a driving test. The disadvantage is that Trails B is hard for people to understand, so I always do a Trails A first because it's pretty easy, and once they sort of get the hang of it, it gets them back into that grade school mode of connecting the dots, and so they can do Trails B. They can understand what it is you're asking them to do. And the good news is if they can't even do a Trails A, there's no sense in asking them to do a Trails B. And then the most helpful test of all is an Allen Cognitive Level. And this is what an occupational therapist is trained to do. There's lots of other functional tests, and an OT certainly is far better expert than I am to tell you about all the testing that they can do. But I like this, an Allen Cognitive Level. It gives you a score from 1 to 6. Scores in the 5s are mild impairment, scores in the 4s are moderate impairment, scores in the 3s are severe impairment, and then if you less than 3 is, severe impairment, mostly bedbound people. And it corresponds to what level of care. It corresponds to how many steps a person can do before they need another cue. So it's great for treatment planning for people. And it's great for saying, oh, well, this person could move into an assisted living. They may have some challenges when they first get there, but they're going to be able to succeed there most likely. Or this person is never going to succeed in an assisted living facility. They need a higher level of care. So that's so I really like it. It's functional cognition. It's really a problem-solving test. And it doesn't really rely on verbal skills. The OT actually does the test for you in most of the tests, so you can sort of, if you can imitate what people do, even if you can't sort of understand the language so much. So it's not a language dependent test. All those other tests, the MOCA, the SLUMS, are very language dependent. And so that's why education can skew results and give you the wrong impression. So how do you make a diagnosis? And this is a diagnosis of anything. But so history, 85%, that's what they teach you in medical and nursing school. So you need a lifetime baseline. What's changed and when did it change? You can look at the neuropsychiatric symptoms. So there's a neuropsychiatric inventory or a Behave AD. And then you can do cognitive testing. I think it's helpful, but you just have to know what the score means. You can't, a lot of times those things have like, if it scores this to this, it means dementia. Well, that's not true. If it scores this to this, it means mild cognitive impairment. That's not true. Because a lawyer, a judge, a doctor can probably score 30 out of 30 on those tests and be moderately impaired, making really poor decisions and having a negative impact on lots of people's lives. A bus driver, that's not somebody who you want running around in moderate impairment. Functional testing, I think, is the best thing for a practical base for treatment planning. It's the most helpful because then you don't even need a diagnosis, right? You just need to know, how does this person function? Not why are they functioning this way or that way, but how are they functioning and what do I need to do to support them so that they can be the most successful. You also want to rule out reversible causes of deficits. So just a word or two about informed consent and evidence-based medicine. So believe it or not, every time you guys go to see a healthcare provider, they're supposed to tell you the risks, benefits, and alternatives to every decision they want you to make, whether it's choosing to do a test or not do a test, choosing to take a medicine or not take a medicine, have a surgery or not have a surgery. So that's really good information that you should have, as should all of our patients. What I want to point out, though, is for people who have dementia with behavior disturbance, what are the risks of not treating the behavior disturbance? Because there's a lot of pressure from some quarters not to use medications inappropriately. I'm a big fan of that. But unfortunately, sometimes that means let's not use appropriate medications. And I'm not a big fan of that because that corresponds to patients or peers being injured, staff being injured, becoming homeless, which is not a great thing when you're old. It's not great when you're young either, but it's a tragedy when you're old. Social isolation. One of the saddest things I ever heard, we had a fellow who came from the coast, and he came to our hospital with behavior disturbance, and we did an assessment, and we treated him, and he was doing better, a lot better as far as his dangerous behaviors went, and we sent him back to his memory care unit. And about 2 years later, he started to have some more problems. They were not as severe, but so he came back to our hospital. And at the same time, we just happened to have somebody and their family who was also living at the same memory care unit. And the family members of this other person came up to us and they said, "Oh, we know him. All the staff at the memory care unit told everybody to stay away from him. because he's hit people before, so nobody ever talks to him, right? That's what happens when you don't treat things that exist, and I'm not a big fan of it. When I first went to Tuality in the first year, we had somebody who actually came up from Grants Pass, was flown to our hospital, and it turned out this man had delirium, a severe delirium, and a pneumonia that seemed to get missed somehow in the workup in Southern Oregon. But he, in the first day he was there, we had an LPN who could get medicines into anybody. She could encourage, somehow she had a way about her, and people took medicine from her. People who would take no medicine from anyone else. So she went in to give him some medicine, and he actually grabbed her arm and twisted it and tore her rotator cuff to shreds. And she never worked a day again as an LPN. So I believe in treating symptoms before they get severe. That's just me. A word about evidence-based medicine. So I trained, did my residency up at Dartmouth, and Dartmouth is, like many Ivy League places, has a lot of confidence in itself. And it's sort of like you couldn't go through a day without hearing about evidence-based medicine. And, who can argue with that, right? I mean, I don't want you practicing things on me that just for practice. I want you to do things that will work, that there's evidence for. So it's very reasonable. The challenge is with both delirium and dementia that there is no large evidence base. So evidence is not one study. It's not even a couple studies. Evidence is a large collection of studies done in multiple different places by multiple different groups of people that all have a common outcome and recommendations that you can make. That's evidence-based medicine. And the challenge is that there are a lot of things for which there's no large evidence base. So if you only are going to do things where there's a large evidence base, you're going to end up with a lot of don't talk to that guy because he's dangerous, right? So challenges with the evidence for dementia and behavior disturbance are similar to delirium. It's hard to get informed consent from somebody whose brain is very impaired. In general, studies are only done of the easy people, which are the people with mild or mild to moderate impairment. People with severe impairment, it's very hard to study. You can't ask them about their outcomes. You can't get them to rate things about whether it helped or not. And then many studies use medications for breakthrough symptoms, and a lot of times they use lorazepam. And in my opinion, if you're using lorazepam as a breakthrough medicine, you should just throw the study out because I'm not going to believe it. Because it skews your results. It's like giving people a drink or 5 drinks, depending on how many doses you give them. So, what psychiatric symptoms are amenable to treatment with medicines? Paranoia and delusions, hallucinations, depression, if it's part of like a depressive illness, like a major depressive disorder, or a dysthymia, chronic depression, sadness or sort of existential despair, sadness because my husband just died. There's no medicine to treat that. Now, if your husband just died and you're laying in bed in your own feces, that's an illness. It's not just normal grief. But an existential despair, there's no medicine to treat that either. Just, people, if you're in that 1/3 of people who know that they have dementia, know that they're severely impaired, and know that they're not ever going to get better, that group of people can become quite despairing, but that is not a depressive illness, and there's no medicine that will treat that. I'm not saying you might not want to try to treat it because maybe it is depression. It can look quite similar, but if it doesn't get better, it's because it wasn't depression, most likely. It's because it's this other thing. Yes? So If people don't feel like doing things that they used to like to do, that's apathy. If people don't have pleasure in doing things that they used to enjoy doing, that's anhedonia, and that's much more likely to be a depressive illness. Apathy is not technically a part of depression, and there's not great medicines to treat apathy. So yeah, like everything else, you have to do an assessment. And then you choose an intervention based on your assessment. And really the best thing to do for those people is to put as much positive support around them as possible. Anxiety. Is anxiety treatable with a medicine? Who says yes? I got a mas o menos there. Who says no, anxiety is not treatable? So non-committal. All right. Now you're asking me to commit. Okay, so anxiety. Well, anxiety, sort of just little anxiety, anxiety with a little a, is what happens when we're nervous or when we're having a lot of adrenaline running around inside of us. So anxiety as a symptom, it could be just normal, right? So you're standing there, your child is in the middle of the street, and there's a logging truck barreling down. Well, if you're not anxious, there's a problem, right? That's a normal reaction to be anxious, and the purpose of it is to spur you to do something to prevent, the child from being run over. So that's normal anxiety, and there really isn't a medicine for that. Now, generalized anxiety disorder may be treated with medicines. Panic disorder, yes, that's probably helped with medicines. Obsessive compulsive. So certain anxiety disorders are treatable, but the symptom of anxiety, if it's a normal reaction, like I'm anxious because I don't know where I am, there's no anxiety medicine that's going to help with that because there's no pill that's going to tell me where I am. So and you have to assess. So sometimes yes, sometimes no. Pain. Pain is very treatable. You should look for it and treat it where you find it. And people with dementia and people with delirium are not going to be able to be good reporters of it. So you have to look for nonverbal clues. Agitation. Agitation is sort of I hate the word. And so I used to say, when people would say, so-and-so is agitated, I used to say, there's no such thing as agitation. But then I realized that I was not helping. So, because what I really wanted was information about what they were doing. So now I say, okay, that's great. What does their agitation look like? What are they doing when they get agitated? So I got over myself and, tried to help people. What isn't treatable with medicines? Wandering is not treatable with medicines unless you give somebody enough medicine that they're comatose and laying down. And I don't recommend that. Matter of fact, I recommend against that. Calling out. The most common reason for calling out is actually pain. So repetitive calling out. The most common reason that happens is because somebody is in pain. Now, sometimes it happens because somebody has what we call self-stimulating behavior or they're very disinhibited. If it's that, there's no treatment for it. So you just have to find out if there's some music or something that helps them call out less or something that covers up the noise, or you can move this person to a facility where they have lots of people who call out and their staff manage to tolerate it, but there's no medicine for it. Repetitive questions in somebody who has Alzheimer's who can't form a new memory, again, the only way to stop those repetitive questions is to make them comatose so they're not talking. And I don't recommend it. Anxiety about having a problem, such as memory loss. There's no medicine for that. Psychomotor agitation. There is no medicine for that. And in fact, often it's caused by a medicine. In my experience, the most common cause of psychomotor agitation in older adults is an SSRI, so one of the newer kind of antidepressants like fluoxetine or Prozac, Celexa, citalopram, escitalopram, Lexapro. SSRIs have a lot of akathisia, which looks like psychomotor agitation, so severe restlessness or pacing. Restlessness or pacing, and moving around. Sleep problems. For the record, I try and treat sleep problems in all of my patients who have dementia and in most of my patients who have delirium. But for the record, don't have high hopes that you're going to find a good medication solution for that. Because usually it's because there's some part of the brain that isn't working. And so if you have a medicine that fixes that part of the brain, well, great. But more likely, you don't have a medicine for it. So, dementia-specific medicine. So I've got a bunch of slides in here, and I'm going to sort of go over them pretty quickly. There's lots of stuff. There's several handouts about this in your packet. And what I want to do is I want to advocate for the use of memantine, which is the generic name for Namenda, and donepezil, rivastigmine. Donepezil is the generic name for Aricept. Rivastigmine is the generic name for Exelon. Comes in pills and patches. And galantamine, she used to be on the VA formulary, and I can never quite capture what its non-generic name is. So I would like to advocate for the use of these medications, and I'm going to show you why. So this is an interesting graph that tells us, it's from a large study of over 60,000 people in Europe, where they actually have good data about things. And it is what, at the time that somebody was diagnosed with dementia, what were they on? So this top group here are people who had dementia. And this bottom group here are people who never developed dementia. So they did a back look, right? So they looked at people who, because you can't tell in the future who's going to be diagnosed with dementia. But what you'll see is there's a high use of antidepressants, antipsychotics, and hypnotics, much higher than average in people who later are diagnosed with dementia. And again, I will tell you that this is because dementia is a behavioral illness. And far before you see those memory and cognitive impairments, the behavioral symptoms are evident, and people try to treat them. And so it's a behavioral illness. This is, so at the far right of this, where there's 0, is where people are diagnosed with dementia. So right here and right here. And again, these are people who were later treated with memantine or a cholinesterase inhibitor like donepezil or Aricept. And they went back and they looked, and they saw that the people who were later treated with these medications that are, I would advocate, are used for the behavioral symptoms of dementia, most of them were on, most of them were having antipsychotic use or antidepressant use before they were diagnosed with dementia. So again, the behavioral symptoms are showing up first. And then finally, this is so right in the middle, that line in the middle of these two graphs, on the left is antipsychotic and antidepressant use in people who are on a cholinesterase inhibitor. What I want you to see is that it's leveling out. So people who had Alzheimer's disease or Lewy body disease, vascular dementia, are not on this graph. But what you would see for them would be a significant increase in the use of antipsychotics and antidepressants. But people who are on cholinesterase inhibitors, it levels out. And on the graph at the right is people who are on memantine. And what you'll see there is a decrease in the use of antipsychotics and a leveling out in the use of antidepressants in people who are on memantine. And this is, you can't really draw causality totally from this type of study, but this is highly suggestive that these groups of dementia-specific medicine treat these symptoms. And the most dramatic case that I saw recently was we had, and it was the grandmother of one of the nurses at the organization I work for. And she had just been moved into an adult care home, but got very paranoid and aggressive, and so she ended up in a nursing home. And she was paranoid, and she wouldn't talk to her grandmother anymore, her granddaughter anymore. She wouldn't talk to her daughter, who was her healthcare power of attorney, anymore, because they were trying to kill her, they were trying to steal her house, and she wasn't eating and she wasn't taking any pills at the nursing home because those people were trying to poison her. And she was like, so I got this frantic call, and I said, well, hey, I'll meet you. So I met the primary care provider and the nurse on the team at the care facility, and I had them bring with them, because the nursing home cannot give an as-needed shot of an antipsychotic to someone in the nursing home, but they would allow us to do that if we came there. So I had them bring the shot. The nurse refused to give the shot because he said it was unsafe, but the PCP said, well, sure, if she needs it, I will give it. And so they came with the shot. So we came, and I went there. Well, she was really cute, but very paranoid. But she talked to me and told me all about, you know, the granddaughter and daughter trying to steal from her, and about how the staff was trying to poison her. And while I was there, so the staff helpfully came in to try and give her some medicine while I was there, because she was calmer, and that didn't go anywhere. But what I also had them bring, besides a shot, was I had them bring an Exelon patch, a ribostigmine patch, which is a cholinesterase inhibitor. And because we had informed consent from the person, healthcare power of attorney, we didn't have to get informed consent from her, because she was unable to give informed consent, because she's quite impaired. But so we sat there and talked to her. She wasn't aggressive. And so we said, well, there's no need for an IM injection of an antipsychotic, because she clearly was psychotic, but she wasn't aggressive. So there's no emergency here. But we managed to get her to sing some songs that she liked to sing, and she used to be a great singer. And while she was singing, we managed to slip that patch on her upper back where she couldn't. And the nice thing, it's a small patch, and she was unaware of it. Well, so we left, and she was still paranoid, but she was much happier. And she was eating and drinking. She did eat and drink while we were there. So it's like, it's all good. No emergency here. Well, by the next day, she visited with her granddaughter. She wasn't yelling and screaming. She took meds. She wasn't paranoid. Now, she had really severe symptoms, and that's the best predictor, actually, of things working. So, but that helped me with this one team. You know, I have 15 teams that at my organization who I work with. And this PCP and nurse and their team became convinced. You know, they were a little doubtful when I said, oh, this is a treatment. This helps prevent this. They didn't really believe me, I don't think. But they're believers now. And so this is a study. And the key point on this study, that again, they were treating people and following people's neuropsychiatric inventory. Yes.
Do you know the efficacy of these medications for end-of-life symptoms?
There is no evidence and no good reason to think that if somebody doesn't have dementia, these are not, in general, medicines to treat delirium, which is what you're usually seeing at end of life. The one caveat would be if somebody is on lots of anticholinergic medicines, like so sometimes people are on atropine for secretions at the end of life. And so that group of people actually can be helped. Their delirium can be lessened by using a cholinesterase inhibitor. It's totally off-label. You're never going to see, probably never going to see a study of it. But and the other group of people who have severe constipation at end of life from all the anticholinergic meds, you can actually treat that with a cholinesterase inhibitor, like donepezil or Aricept. Off-label. I've never seen a study of it. I've done it with success for some people.
What antipsychotic shot did you bring with you with the Exelon?
It was an atypical antipsychotic, and what I'll tell you is there's not a lot of difference one to another. Right. It happened to be olanzapine, but it could have easily been anything else. So the key thing from this study of memantine that I want you to take away is people who didn't have aggression at the start of the study, people who were on the placebo were much more likely to become aggressive over 24 weeks. People who were on memantine were much less likely to become aggressive. This is the kind of thing that leads me to believe that memantine helps prevent the emergence of aggression. It does treat it if you have it. It decreases the severity and incidence of it. May not prevent it, but it also prevents the emergence of it.